Recording in progress.
Good evening, everybody. Good evening, everybody. Good evening, everyone, all my doctors. On behalf of Sun Pharma, I welcome all of you to this wonderful evening, where we are going to discuss the GI manifestation in COVID, a case-based approach. On behalf, I'm Salil Pandey from Sun Pharma head office, and I have the pleasure with me entire my Sun Pharma head office team. And one thing I would like to say before I get into the details, today, every year, 29th May is celebrated across the world as a World Digestive Health Day, with a focus on several GI and related disorder in order to increase the public awareness on several GI complications in terms of its prevalence, in terms of its diagnosis, prevention, as well as treatment. This year, we are into the midst of the pandemic. When we all started believing that COVID-19 has been a nightmare of the past, it has hit us, and it has hit us badly. And currently, we are battling with the second wave. And during this time, sir, I think all of you will agree with me, the GI complications along with associated with COVID has increased manifold. Sun Pharma has always been committed, is always committed to to better the GI health by partnering with the medical fraternity and creating a very strong knowledge sharing platform for all the consultants, including gastroenterologists and physicians, for share their ideas and experience in this platform. Today, I am very happy that we have today with us the eminent gastroenterologist of the country, and along with that, the lot of seniors and consultant physicians of the country who are going to take us through, as far as their experience is concerned, how they have been managing the GI complications during this COVID period in their clinical practice. I am sure it is going to enlighten us in a lot of different aspects, and we all are going to be benefited out of the experience, practical experience that the senior consultants are going to share, where senior consultant gastroenterologists are going to chip in and they are going to share their views on the overall aspects of GI manifestations of GI problem during this pandemic. With this, I hand over the session to Dr. Mahesh Goenka, and it's over to you, sir.
Thank you, Salil, and must thank Sun Pharma for providing this platform on a very important day. Along with my co-chairman, co-moderator, Dr. Ajay Kumar, who is the chairman and HOD of Gastroenterology and Hepatology at DLK Max Super Specialty Hospital. This is Dr. Mahesh Goenka from Apollo Clinicals Hospital, Kolkata, welcoming you. As Mr. Pandey said, that we are going to discuss today in a different format than most of the webinars are. We are going to discuss 5 different cases, trying to cover whole gamut of GI and liver manifestation and relationship between GI and liver with COVID. While COVID continues to be predominantly a specialty for pulmonary medicine, with a majority of the issues related to pulmonology, we over the last 1 year have realized that there is no specialty which is not involved while we are managing COVID. And in the second wave which we are going through, we have realized even more that GI, both luminal and liver, is an important component of managing GI liver COVID-related diseases. So we have, besides Ajay, Dr. Manu Tandon from AIG Hospital, Hyderabad, Dr. V.G. Mohan Prasad, Chairman of VGM Hospital, Coimbatore, who is going to join us very soon, and Dr. Akash Shukla, Professor and HOD Gastroenterology of KEM Hospital, Mumbai, who are here as the resource persons and would be discussing the various cases. We have other specialists, both gastroenterologists, internists, who will be presenting the cases, and we have carefully selected 5 different varieties of cases to give the whole spectrum of GI and COVID. So each of these presentations will be for about 10 minutes, followed by 10 minutes of discussion between the various panelists, and we will be happy to take any of the chat box cases, questions if there are one, and we'll go through this over the next almost 1.5 to 2 hours. With that, I would invite Dr. Ajay, the co-chairman and co-moderator for this particular session, to give an overview of the subject before we have the first presentation from AIG Hyderabad. Ajay, please.
Good evening, friends. Greetings on this particular day of a World Digestive Health Day. And today, the topic for discussion through the entire 2-hour session is related to the COVID-19 and GI tract. When I say GI tract, I also mean to say liver and pancreas as part of it. See, there are all of you have a much bigger experience in handling COVID than we as a gastroenterologist. But we always come into picture whenever there is a GI or a liver involvement. And there are various aspects over the last 1 year or so. We have all learned that there are multiple aspects to it. But broadly, when we divide into two broader categories, one, in a patient who does not have pre-existing GI and liver disease, but presents with a fresh case as a COVID, and COVID causing some GI manifestations. That is one part which can have a problem with the initial diagnosis. And to also we like to understand that does it indicate severity of the disease? Does it have an impact on the outcome of COVID? Does it leave any permanent residual injury? And so on. And does it any way change our treatment? So my 5 minutes presentation will be only focusing on the first part. The second part, that with the pre-existing GI disease patient, whether it is a IBD, whether it's a patient of a liver disease, cirrhotic or post-liver transplant and so on, there could be different aspects. When they develop COVID infection and what is the outcome of that and what do we understand, that is something which we decided to take up in a case capsule format. So let me talk about the work assigned to me that we all, I don't want to spend too much time on this, but you all know it better than me, that it is a pandemic declared in the month of March 2020. In fact, the day it was declared as a pandemic, both me and Mahesh were in Rio attending the World Endoscopic meeting. And initially what we understood, that is a primarily respiratory tract involvement. But then, as the things evolved, the initial reports came from China, because the virus originated there. So it showed that the 26% of our patients can have GI symptoms, out of which predominant is the diarrhea and nausea and vomiting, and some of them can have abdominal pain. Of course, later on we know that anosmia, agusmia, this is a report which came from initially from USA, that some of them, it can become a diagnostic thing, whether you want to put it into a GI tract, but that these became very important symptoms because patients complained of it and you start suspecting that this could be COVID. The interesting thing is that 16% of patients could have GI symptoms without associated respiratory symptoms. So a patient presents to us in the OPD with a fever and a diarrhea, then again COVID has to be suspected. But good thing was that most of the time these are mild symptoms. And this was again found out the mechanism of that is the same, that the ACE2 expressing cells and the TMPRSS, these proteases, they act as the co-binding protein. They are basically initially said they found in lungs, but then they found in the entire intestinal tract and also in the cholangiocytes, as well as in the pancreatic islet cells, as well as the exocrine cells. And large number of us are aware of this diagram. They become familiar that this is the COVID-2 spike protein, ACE2 receptor, and that's what binds here. And TMPRSS is a cofactor, and without that you cannot infect the virus, and virus involves the intestinal epithelial cell as it involves the respiratory cells and can cause diarrhea in a significant number of patients. And it can also, a number of other manifestations have been reported. I'm just showing you one of the endoscopic pictures of esophageal ulcers, then this could be due to superinfections or co-infections associated with that. The question came that do GI symptoms predict course or the severity of the disease? Whatever we understand, no, they do not predict the severity of the disease. I'm talking about the purely GI symptoms. Can they persist after recovery of respiratory symptoms? Yes, they can persist for a longer time, but not necessarily that they are infective. Initial speculations that you found the virus in the stool and it existed even after the respiratory virus has become negative. It raised the possibility that it could be causing fecal-oral transmission, but it has been subsequently shown that it does not cause fecal-oral transmission because these are the fragments of the virus and not the entire virus that you see there. Does it leave any permanent sequelae? We don't believe that it leaves any permanent sequelae. Yes, a lot of these patients develop IBS, dyspepsia, which is more related with other psychological issues that they get, which we all are familiar with it. And of course, how common are the opportunistic infections of the GI tract? One of the case capsules we'll discuss about that. Then the second part was the liver, abnormal transaminases in 22%, raised bilirubin in 10%, and 40% patients with severe disease have it, but only 18% of patients with mild disease. So it does not mean that if you have raised transaminases, it indicates severity of the disease. What I'm trying to say here is that the patients who have a severe COVID disease, in that disturbance of the liver enzymes is more common than in the mild patients. And there's a number of reports on that. I'm not spending too much time on that, just saying that abnormal liver enzymes is an important, significant feature associated with COVID infections, but it does not indicate the severity of the COVID disease per se. Most of them have hepatocellular injury pattern, and there is a mild to moderate elevation. Mild elevation of bilirubin up to 5 milligram is usually transient and improves, and it can take longer time, 4, 8, 12 weeks, even after the recovery of the patient. Low albumin is a risk factor. Acute liver failure due to COVID virus per se has not been reported to the best of our knowledge till now. Okay, the mechanism and the pathology, I'm not going to details of that. It only shows there is a non-specific pathology. Very few reports are available. So when the patient of COVID has a deranged liver functions, how do we approach that? Definitely, we like, because that does not mean that the patient cannot have associated other infections. We like to test for the viruses, hepatotropic viruses, and then review the drug history as well as ethanol. There's a large number of medicines which people have been taking as immunoboosters. Our personal experience is that some of them take too many of these and too much of amount. I'm not saying that those are harmful. What happens is some of them are consuming too many of these karas. And the culprit that we have tried to identify, we have no direct evidence by history taking that Gilois consumed in very large quantity. There was a person who was consuming almost 3 to 4 different types of karas in a day. They have a severe drug-induced liver injury. We had to do even liver biopsy and rule out. And this patient, there are 3 such patients with us who had taken almost 3 months to recover out of that. So we have to make sure such drug histories and a history of alcohol. If other than that, we do not go rush in for the ultrasound and so on. Yes, ultrasound, up to ultrasound is okay, but not beyond that. But only if the patient does not improve after the recovery of COVID, then we start looking at the other alternative causes. Then, of course, the main thing to be mentioned that remdesivir is a hepatotoxic drug, so we should be cautious in giving it, and so is the tocilizumab, and both of these can cause problem, and we should not be very cautious in using these 2 drugs in a patient with a disturbed livers or existing liver disease. So in conclusion, for the liver, COVID liver injury is typically hepatocellular, mild, and transient. Mechanism of liver injury is unclear. Viral markers alcohol history, and drug history are important to make sure that we are not missing something more. The last two slides on pancreas. As I said, ACE2 receptor expression is both in exocrine pancreatic cells and islet cells. Pathogenesis is multifactorial, is a direct virus mediated, or a systemic inflammation and pancreatic injury in severe COVID can occur, and virus mediated injury to the islet cells, damaged by the pro inflammatory cytokines, and all of us are aware about the interleukin, virus induced lipotoxicity, and drug induced pancreatic injury, especially from NSAIDs and corticosteroids. If raised amylase and lipase can occur in almost 15%, but classical acute pancreatitis, where you have 2 to 3 times rise, and classical pancreatic pain occurs in about 2.8%, and it is more in the severe patients, severe COVID, and then in mild disease. Again, that does not indicate that it is a parameter of severity, but severe patients, because there is an isolated lot of associated hemodynamic disturbances, can have a lot of these problems. So, friends, I just wanted to share in this 55 minutes that these are the manifestations which can occur in a patient of a COVID, and we should be just cautious in two factors, that we should not be missing any associated diseases with that, which patient may be harboring. We have seen patients of a compensated liver disease getting COVID and getting decompensated. So we should be on the lookout for that. Otherwise, they should not be alarmed. And with that, I will pass on to the case capsule, pass on to Mahesh, and we can proceed with the cases.
Thank you, Ajay, for set the ball rolling and introducing the subject. I think now we'll move on to the 5 cases, one after another. And I would only request everybody to be precise so that we have some time left. We would not be able to extend any of these presentations beyond 20 minutes as we discussed. So do your presentation fast so that we can have some meaningful discussion. With that, I invite the AIG team. We have a presentation by Dr. Mohsin Aslam, who is going to talk about the AIG experience, followed by Dr. Parth Gopal, the gastroenterologist, and Dr. Manu Tandon to discuss the first case capsule. Dr. Mohsin Aslam.
Yes, sir. Thank you, sir, and thank you, Ajay, sir, for enlightening us on this manifestations of GIT manifestation COVID. So, whatever sir has told, I'll be elaborating this, and with our experience, what ours is a gastro specialty center. So, most of the patients come here with GI manifestations. So, when the pandemic was declared in March 2020, it was considered as a primary respiratory disease. So even in the WhatsApp groups, everywhere in the media, it was shown yes, people who have fever, breathlessness, cough should immediately report to the hospitals, get themselves checked for the COVID. And yes, everybody started checking for the symptoms. Even with mild sore throat, they were rushing for the RT-PCR test and started checking their oxygen saturation. But none knew there might be some other manifestations like involving GI tract, like vomiting, pain, abdomen, nausea. So at that point of time, whenever the patients, they had any loose motions or vomitings or pain abdomen, they used to rush to the hospitals, especially our gastro center. And whenever we used to ask them to get a COVID test, they used to deny, no, sir, we don't have any COVID features. We don't have fever. We don't have sore throat. We don't have any loss of taste. So unlikely. So because of that lack of knowledge, unnecessary, there was an exposure to more number of patients, especially the healthcare physicians. So now as the knowledge has increased, we should be very careful and treat otherwise unless proven all the symptoms as we have to suspect COVID in all the patients. So I'll be sharing our data. So from the last 1 year, we have seen almost 1664 patients who presented to us with varied manifestations and turned out to be COVID positive. So the mean age of the patients was around 43 years and almost 60% of them were males. So young male population during post-lockdown after the first wave, who were going out for the work, they were more exposed to the viruses, maybe at the workplace or in the restaurants, having outside food, and they presented with GI manifestations. And coming to comorbidities, 15% patient had diabetes, 10% had hypertension, 22% had obesity. Hypothyroid was seen in 10% of the patient, and 1 to 2% patient had coronary artery disease or respiratory illnesses like COPD, asthma, obstructive sleep apnea, and chronic kidney diseases. And all our patients had mild to moderate disease. None of them had severe disease, and none of them had any breathlessness, so needing hospitalization for COVID management. So among the presenting symptoms, generalized weakness was seen in all the patients. Fever was seen in 61% of the patients, cold 28.2% patient, cough 40% of the patients. Breathlessness was not seen in any of the patients. Loss of taste and smell in 42% of the patients. Coming to GI manifestations, loose stools was the most common presentation seen in 66% of the patients, followed by anorexia 64%, then nausea 55.5% of the patient, pain abdomen 53.5% of the patients, vomiting in 32% of the patients. Then jaundice or altered liver enzymes were seen in 2% of the patients, and GI bleed in 1% patients. So among of the 1,664 patients, almost 73% patients had GI symptoms. Even the literature, various studies have shown from GI manifestations ranging from 16% to up to 53% in one of the Chinese studies. And even in one retrospective study by Massachusetts, it was shown nearly 62% of the patients had at least one of the GI manifestations. And among GI manifestations, anorexia, loose stools, anorexia was the most common manifestation, then loose motions, pain abdomen, and then nausea and vomiting. And in our population, nearly 39% patients presented only with GI symptoms, and they never had any other symptoms, including fever, cough, or breathlessness. So this is a really very high number, because I was again a gastro center. So most of the patients thinking they don't have any COVID and it may be just simple GI disorder, they rush to us. And in one of the studies, it was shown that 10% of patients had only 10 GI manifestations. And even now coming to GI manifestations, among GI manifestations, again, loose stools, out of that 1,200 patients, 88.5% patients had loose stools, 87% had anorexia, then pain abdomen 73% of the patients, nausea 75.8%, vomiting with 43.8%, jaundice or altered LFTs were seen in 2.6%, and GI bleed in 1.3% of the patients. Now, these were the patients admitted in our ward because of the medical gastric problems. So they were all follow-up patients who had CLD, and they presented with decompensation. Almost 32 patients presented with decompensated CLD. Chronic pancreatitis patients, 28 presented with acute attack of chronic pancreatitis. 16% had acute calculous cholecystitis. 6 patients who were diagnosed to have on evaluation presented with ascites or pain abdomen, had abdominal coughs, and even they turned out to be RT-PCR positive. 2 patients out of the GI bleed had Mallory Weiss, and RT-PCR was positive. 7 patients with IBD flare-up by increased frequency of stools, pain abdomen, and bleeding per rectum, they turned out to be COVID positive. 4 patients with colonic polyposit patients had who were supposed to undergo polypectomy turned out to be COVID positive. 1 patient with colonic mass, probably malignant, had
Mohsin, we will move a little faster, Mohsin.
Yes, sir. And 1 patient presented with recurrent vomitings and pain abdomen following gastrojejunoscopy had gastric outlet obstruction. So we don't know whether this were the this decompensation or acute thing was because of the COVID-19, or this COVID-19 was an incidental finding in these patients. Thank you.
Thanks, Mohsin. I'll give the comments at the end. I pushed him because we have to stick to the chairperson's time of 5 minutes. Partha will do the same with the unusual case that was COVID positive GI complaints. Partha, the stage is yours.
Thank you, sir. So, is my screen visible, sir?
Yes.
Yeah. So,
Yes, visible. Go ahead.
So today we discuss a case of a COVID-19 in a case of pre-existing GI diseases. And interestingly, this patient had two pre-existing GI diseases, one related to liver and another related to lumen. So this is an interesting case we are going to discuss today. So this was a 29-year-old male who had, at the age of 29 years, this patient had a self-limited jaundice for 3 months, for which he was not evaluated at the time. And then he had diarrhea with hematochezia, and later on he was diagnosed with ulcerative colitis, and he was maintained on 5-ASA and steroid, followed by 5-ASA. He was in remission for the last 9 to 10 years. He had a flare last year, which was treated with steroids and later maintained on 5-ASA. Recently, in April 2021, he presented with cholestatic jaundice and relapse of bowel symptoms. At that time, platelet counts on investigation, platelet counts were high. ESR was also elevated. There was LFT showed both transaminitis, jaundice, and elevated alkaline phosphatase and altered AG ratio. GGT was elevated. At the time, ANA, all the viral screens were negative. IgG was advised, but he did not do it at that time. Endoscopy did not show any varices. Ulcerative colitis showed features of pancolitis with a severity score of 4/8. Few polyps were also there, and which are pseudopolyps and inflammatory polyps. And on MRCP, there was intrahepatic ducts were there were segments of narrowing and prominence, a beaded appearance suggestive of primary sclerosing cholangitis. Later, he had fever, and at that time, RT-PCR was tested, which was negative. He was prescribed highest dose of 5-ASA with UDCA and antibiotics for oral antibiotics, and asked to follow up. At that time, the bilirubin has come down, although the transaminitis persisted. And as the LFT showed improvement trend and the bowel symptoms improved, he did not turn up for scheduled follow-up. And later, on 1st May, he came with fever and cough for 3 days. At that time, the bilirubin went up to 8.5 with increase in transaminase levels. At that time, RT-PCR was positive. And he had most probably a mild COVID infection. Initially, the CT scan showed a Corad's 4, but he did not consult any physician and only took antibiotics, multivitamins, supportive measures. No blood investigations were done at that time. He was in home isolation. And later on, after 15 days, he presented to us with abdominal distension and progressive jaundice. At that time, he was afebrile. RT-PCR was negative. Hemoglobin was little low compared to the beginning. Bilirubin has increased to 11.8 after admission. And there was urine examination. There was trace protein. INR has deranged now, 1.51. And at that time, CRP, procalcitonin were done, which were mildly elevated. Ultrasound was done, which showed hepatomegaly with coarsening of ecotexture of liver, periportal cuffing, thick walled CVD, splenomegaly and ascites, and bilateral acute renal changes and thickening of colon. Then post-admission, he had daily fever spikes. He had non-oliguric AKI. Creatinine was 4.4 on admission, who did not respond to volume expansion and metodrine. And later also bowel symptoms also worsened, but it was managed conservatively. And CT scan showed bilateral minimal pleural effusion, few fibroelectric obesities, high SAG, ascitic fluid was high SAG, there was no SBP. Urine 24-hour protein showed protein levels almost near to 1 gram. RT-PCR, manually antigen, Vidal, and NS1 was done, which was again negative. So he underwent hemodialysis 2 times, and later on renal biopsy was done. And after admission, LFT showed improving trend spontaneously. So cholangitis was unlikely. So we waited. We did not do any ERCP. And fungal culture from the sputum showed candida, albicans sensitive to fluconazole. After starting the fluconazole, the fever has responded a little bit. The renal biopsy has come out to be acute tubular necrosis, and there is some pigmented cast. So there was a possibility, the pathologist raised the possibility of bile cast nephropathy, which was unlikely in the presence of decreasing bilirubin trend. So it was a case of ulcerative colitis with primary sclerosing cholangitis. He may need a liver biopsy to rule out autoimmune hepatitis PSC overlap because he had significant transaminitis as well. And later on, we repeated the IgG, which was almost 12,000, and he had a mild COVID-19 infection. And post-COVID, there is decompensation of liver disease. There is persistent fever, ongoing sepsis, and there is AKI. Biopsy showed acute tubular necrosis. although there are reports of this COVID-19 related acute kidney injury, different mechanisms has been described, and there is ulcerative colitis mild worsening. So this autoimmune hepatitis and PSC overlap. There are entity in between the autoimmune hepatitis and PSC who respond to immunosuppression less than autoimmune hepatitis, but more than PSC. So there is a role for immunosuppression may be present in these patients, but we did not do a liver biopsy until now. So these are the data presented from our center earlier last year. In this, we have shown that SARS-CoV-2 infection, there is upregulated ACE2 receptor expression because of hypoxia and cytokine storm. The receptors are overexpressed, and because they are present in cholangiocytes as well as in hepatocytes, although most of the injuries hepatocellular, there may be cholangiolar injury as well as leading to cholestatic picture as well. So this severe SARS-CoV-2 related ACLF patients have prolonged hospital stay, severe COVID-19 illness, and need for ICU stay and higher mortality as compared to patients without ACLF. Although in this patient, this patient had mild COVID illness, and most of the patient has respiratory failure and liver failure are the most common cause of death. Few of the patients have sepsis also, and whether immune dysregulation is different in these patients from other causes of ACLF needs further evaluation. So these are because the patient has also ulcerative colitis. This is our experience from AIG of the patients who had coexistent COVID-19 in patients with IBD. Most of the patients are symptomatic, and few patients are asymptomatic as well. The COVID-19 severity, severe disease.
We'll have to go a little faster.
Last slide, sir. So COVID-19 severe disease was only 11%, which is compared to the secure IBD registry, which is a worldwide registry, which reported 20%. Hospitalization, we reported 23%, which is according to the international data, it is almost comparable to 30%. And most of the patients, 40% patients continued their IBD medications, and the COVID-19 severity in the patients who had biologic use was not significantly higher than compared to other medications. And most common symptom was loose stools in this patient. Thank you, sir.
Mahesh, can I make a few comments before I take the questions, Mahesh?
Yes, Manu, you have any comment to make? Yeah, you have any comments to make, Manu?
Yeah, to both. I'll take them one by one. Now, Mohsin gave us our data. Mind you, if you remember Ajay's data, there was 16 to 18% GI complaints, and ours were close to 60. This is purely because it is a biased population. We have two centers where Mohsin has collected data, is where I also work, is purely a gastro center and not a general workup. So people who come in are primarily a gastro complaint patient, and that is why the incidence is 63. And the thing to be stressed is not only what Ajay has told, but review of literature and what people who have pure gastro symptoms have got a much better prognosis than those who develop gastro plus respiratory symptoms. And quite a lot of them do, but the ones who remain gastro fortunately have a better prognosis. So that is a comment on Mohsin's data. Partha's case, which is a combination of ulcerative and PSC, and for those of you physicians who must know, all PSCs between 85 to 90% have ulcerative colitis. And out of the known ulcerative colitis, 4 to 5% will have PSC. Now, this is a combination which as such is very serious, with the ultimate treatment, if everything fails, is a total colectomy plus a liver transplant. Now, Partha presented case where unfortunately, the patient had both these manifestations. He developed COVID and there was worsening of both the symptoms. He is not yet out of the woods. He's on our follow-up. We are taking care of him. But just wanted to tell you how deterioration, I'm sure Akash, who's going to talk about liver disease, and Ajay also will tell us, Mahesh, of course, is talking about a different case, will tell us how there is a deterioration both in the liver and in the bowel function following COVID. Mechanisms are not clear. Ajay clarified, but somewhere or the other, we have deterioration. So that was my comment on both the things.
Before we open this,
yes.
Partho, can you tell us whether we know that ACE receptors are very commonly seen on cholangiocytes more than the hepatocytes? So is this PSC worsening because of the bile duct involvement, or you think it's a hepatocellular dysfunction because of the COVID?
So actually, both the transaminase levels as well as the alkaline phosphatase levels both are worsened. So although in COVID, mostly hepatocellular injury has been reported, there are some recent reports of this post-COVID cholangitis or cholangiopathy. Reports of cholangiopathy has been reported. Although they are in very severe COVID, this has been reported, but that still can occur. And those patients don't initially have PSC, but they have developed like critical illness, secondary sclerosing cholangitis. The 3 reports this month, American Journal of Gastroenterology, the published report. So although the main mechanism is hepatocellular, some patients may have this bile duct injury as well.
This is interesting because we all know that it's mostly cholangiocytes which has ACE receptors rather than hepatocytes. Though receptors can be there in the hepatocytes also, but most of the reports are on hepatocellular dysfunction. But I'm sure a patient like PSC may deteriorate. Akash, you have any comment to me?
Thank you, sir. So, as you very appropriately said that the SARS, the AS expression is much more on the cholangiocytes, and therefore we are expected initially that the involvement of the biliary system would be much more. The mechanism for the hepatocyte injury is actually like a bystander hepatitis because of the systemic inflammation and antigen-antibody complex deposition. So, but in the second wave, there are far more patients who have come with cholestatic features and biliary injury. So we have had one patient who has developed sclerosing cholangitis around 2 to 3 weeks after the recovery from the acute COVID. So I think this is a huge area of for future research.
Ajay, last comment from you before we move on. We have already finished 20 minutes. So Ajay, last comment.
No, I just want to ask from Ashish and Manu and Partha, anybody, I mean, Mahesh, even, have you come across this traditional medicine-induced drug injury? The traditional means the ones which are being currently used for, say, immunoboosters. Because we have seen very... I would
tell you at least we have 4 documented cases of very bad hepatitis after so-called alternate medicine, which is Giloy. And I would say that we have patients who have taken just 3 or 4 doses of Giloy because there is no pharmacological dose which is known to anybody. So even 4 doses of large amount of Giloy, and we lost 2 of them because of so-called drug-induced hepatitis. We actually did biopsy on 2 of them, and we found that there was evidence of drug-induced hepatitis. So I think it's a warning for everybody, and through this panel, we want to convey that don't go for these prophylactic measures because which are not well. So very important point.
Allow me, I can modify it without. Let's not give it that whatever you take, don't take too much of doses. I mean, excess of everything, all this is bad. I mean, to be playing on the safe side in the current era, debate going on, I think that would be a better thing to say. I think, and all these people who develop liver injury were consuming 3 to 4 types of kadas every day. No, that's my observation.
It's a very important warning and very, very important warning. Manu, if you have any comments, otherwise we'll move on. You have already taken 21 minutes.
Yeah, I think we'll move on. There are a few questions, some related, not we'll take them with the rest.
Okay, so maybe when we talk about other GI or liver cases, we can answer some of them. Akash, it's your turn now. So Akash Shukla is going to present his case, and then we'll have a discussion, and Dr. Girish can join us in the discussion.
Mesh, you can introduce Akash.
Yeah, Akash, I already introduced. Dr. Akash Shukla is a very senior gastroenterologist and hepatologist, and he is presently the professor and HOD gastroenterologist at famous KEM Hospital, Mumbai.
At the outset, I would like to thank Dr. Mahesh Goenka and Dr. Ajay Kumar sir and Sun Pharma for giving me this opportunity. I would present this case on behalf of myself and Professor Girish Rajyadhyaksh, who is the professor and head Department of Medicine at the BYL Nair Hospital, Mumbai. So, this is a 69-year-old lady diagnosed to have autoimmune hepatitis in August 2019. At that time, she had her first episode of decompensation. She was child pugs B with a score of 7, and she had grade 2 esophageal varices. When we looked at her past history, she had bronchial asthma for 15 years, for which she was on formoterol and budesonide metered dose inhaler twice a day and well controlled. She was started on steroids, azathioprine, spironolactone, and supportive therapy for her autoimmune hepatitis. Her ascites responded to diuretics, and the LFT became normal. In August 2020, that is a year after her original diagnosis, she developed fever, 101 degree, with cough and dyspnea. A rapid antigen test was positive. In view of her history of decompensation and a fever of 101, cough, dyspnea, and comorbidity of bronchial asthma, she was hospitalized. On admission, she had wheezing. Her saturation was 94%. Her blood pressure was normal, pulse was 108, and a respiratory rate of 28 per minute. There was no ascites, jaundice, or encephalopathy at this stage. An X-ray chest was done, which was normal. Paracetamol was given. Her bronchial asthma management was started with increased dose of MDI along with the use of a spacer because she was tachypnic. The bronchospasm got relieved. The saturation increased to 97% with this, and the respiratory rate came down to 20 per minute. Since we were not sure of the safety of the drugs at that time in August 2020, so we decided to give the COVID plasma-19 therapy, plasma therapy, so convalescent plasma, on the day of admission, which was the day 2 of fever. So within 48 hours of admission, she had received her first dose of COVID-19 plasma therapy. From our transplant experience, we extrapolated to autoimmune hepatitis, and we stopped the azathioprine. The recommendation is to stop antimetabolites in transplant patients. So we did the same here, and her steroids were continued in the same dose. Plasma therapy was given for 2 consecutive days, 200 ml each time. Her general condition remained stable. The coughing persisted. Her saturation was around 95 to 97%, and there was no fever after the 4th day. Her transaminases had increased to 2 times upper limit of normal. On day 8, her dyspnea worsened with a saturation of 90%, and a CT scan was done at this stage, which showed a CT severity score of 15 by 25. The steroids were increased to 40 milligrams. Because she had fever again, after the discussions with the family and the whole team, a decision to give remdesivir was taken, and the oxygen requirement had in the meanwhile increased from 2 liters to 15 liters over 24 hours. At this stage, she started developing ascites and edema feet. Albumin had dropped to 2.1. Her bilirubin was normal. Transaminases were around 3 times upper limit of normal. CRP had increased to 104, and ferritin was more than 3,000 with the normal procalcitonin. The fever decreased after 48 hours. Diuretics were added, but at this stage, we were considering whether an NIV needs to be started or not. Now, this is 48 hours after we have started remdesivir. So, fever has disappeared, but there's not much improvement otherwise. It was after 48 hours of that the patient started improving, and again dramatically in 24 hours, oxygen requirement came down to 2 liters. Her respiratory rate was 18 per minute. The cough had decreased. The ascites and edema feet, however, persisted despite use of diuretics. There was no pleural effusion. The oxygen requirement also persisted, and we repeated a CT scan at 28 days, which was showing exactly the same changes. In fact, there was more fibrosis and nodularity at that stage as compared to the first one, while the ground glassing had almost disappeared. A decision to start pirfenidone was taken, again with a lot of discussion and care, and 200 milligram thrice a day was started. The patient was discharged on day 18 on 1 liter of oxygen. She became off oxygen after day 24. Gradually, the ascites and edema improved over the next 4 weeks. The LFT became normal. Fortunately, now the patient is absolutely fine clinically. She's off diuretics after 2 months of recovery of the discharge. Currently, the patient is CTP-A cirrhosis, which is better than her pre-COVID illness. And her fibroscan is actually now 10.4 kPa, which is in the non-cirrhotic range. So we started with a biopsy-proven cirrhosis, and now the fibroscan is actually 10.4 kilopascals, which is suggestive of fibrosis and not cirrhosis. So The few points of discussion. The liver abnormalities in COVID-19 are fairly common. They range from 14 to 76%, and they can vary from just mild transient increase in transaminases to very severe or severe hepatitis. Bilirubin increases in around 10% of the cases. GGT increases in around half of the patients, and ascites may develop or worsen in patients who already have them. Acute and chronic liver failure is being increasingly reported, and in the Apocalypse study, we have found that almost 7% of the patients may actually develop decompensation. What should we do if an AIH patient gets COVID-19? So the first thing is to avoid high doses of prednisolone, lower the dose of corticosteroids initially. We may need stress doses in patients who are admitted in ICU to avoid adrenal insufficiency. But otherwise, we should try to maintain these patients on lower dose of steroids, at least for the first week. We know that SARS-CoV-2 may cause lymphopenia, and therefore, it is better to decrease the dose of azathioprine or mycophenolate, or in severe cases, stop them completely. What about the use of remdesivir in patients with chronic liver disease? We know that it's a nuke that acts as a viral RNA polymerase inhibitor in vitro, and there's very limited experience in patients with liver cirrhosis. The experience is mainly based on the use of nukes in patients with chronic hepatitis B and C, where they were found to be useful and safe. But liver toxicity with ALT elevation is possible, and case reports are there even of liver failure. And therefore, for each patient, risk-benefit has to be assessed. No relevant drug-drug interactions are expected with remdesivir. With regards to other drugs, hydroxychloroquine has already gone out of fashion. Tocilizumab has to be given with a lot of caution in patients with liver disease, and in patients with decompensated cirrhosis, it is contraindicated. Also, patients with Hep B can get a reactivation of hepatitis B with the use of tocilizumab, and therefore prophylaxis needs to be given. With the use of methylprednisolone, we have to be cautious about other infections, risk of variceal bleed, as well as risk of bleeding from gastric and duodenal ulcers. Also, if they're used at higher doses or for long period of time, there can be hepatitis B reactivation. With the use of favipiravir, we have to be very conscious because it is metabolized by aldehyde oxidase and xanthine oxidase, and therefore, a lot of drug-drug interactions are possible, especially in patients who are on polypharmacy, and they can cause disulfiram-like effects, and therefore have to be avoided in patients who have been consuming alcohol regularly. Thank you very much, and I'll invite any comments, questions.
Thanks, Akash. Can you stop screen sharing? Nice, good index case. It raises, actually, you raised the questions and answered most of the questions. I just like to know, Akash, do you find, like, what is the common in a COVID ward now? What you're facing is the patients coming as a healthy people, unknown liver disease. Do you notice that a lot of them are getting decompensating, are being freshly diagnosed as a chronic liver disease? Do you face the same issues?
Yes, sir, absolutely. So, in fact, we have quite a few patients who never knew that they had a liver disease. When they got admitted, they suddenly started developing edema, feet, and ascites. I think that to me has been the most common decompensation event. A small minority have developed jaundice. We are right now analyzing the data. I don't have the percentages as of now, but to me, it is the decompensation of the portal hypertension, variceal bleed also to some extent, but more of ascites that we are seeing rather than progressive jaundice.
Dr. Vardhani is a senior physician and actually probably dealing with almost, would have dealt with more than 500 or 700 patients or COVID admitted patients. Dr. Vardhani, what is your experience with the patients of liver disease when they get COVID? How do they behave?
Sir, I fully agree with Dr. Akash. So many patients are developing pedal edema and swelling over the feet, and when we are investigating, and most of them are diabetic and underlying CLD, but they never diagnosed. So during this time, so many patients are going into the decompensation and diagnosed.
Before any of the panelists speak,
Can I make one comment again?
And I just want to ask one, Akash.
Yes.
We faced in 2 patients of autoimmune hepatitis. I mean, something which we have never seen before. The platelets being reported as 0. I mean, we have seen enough thrombocytopenia in cirrhotics and all that. I mean, when it's combined with COVID, that becomes a huge problem in a few cases. Do you also face the same sort of a situation?
Yes, sir. Thrombocytopenia does become a significant problem in patients with who already have cirrhosis and then develop COVID. But sir, again, this is restricted to patients who have got moderate or severe disease. Majority of the patients somehow we have seen even decompensated cirrhosis actually get mild disease, and they actually get away without these complications. So, but in moderate to severe disease, we have seen also, sir. I think a lot of it is because of the drugs which have been used. And I think that also is contributing, with secondary infections also contributing to thrombocytopenia.
So I have 2 comments to make, Ajay. Can I come in? So one question to you, Akash, is you did touch upon use of remdesivir. We all follow that if the basic enzymes, baseline enzymes are more than 200, we are usually avoiding remdesivir. And if we have to start it, we regulate it every day and see whether the enzymes are deteriorating further. But what about a compensated cirrhosis who has a normal liver enzymes? Will you advise remdesivir to be given when your COVID specialist wants to give the remdesivir without evidence of activity in that way? And the second question to you is that when you look at the registry which has been gone for the COVID and liver disease, it clearly mentions that among the underlying etiology, it's the alcoholic liver disease which worsen more than any other. And that site at least says that autoimmune hepatitis does not have a negative correlation with COVID. So you comment on this.
So I'll answer the second question first. That's a very interesting observation that autoimmune hepatitis does not portend a poor prognosis. Very similar to patients after liver transplant, where the Spanish studies showed that the survival in patients who have undergone a liver transplant is better than the general population. So I think the same can be extrapolated to patients with autoimmune hepatitis, at least those patients who do not have advanced decompensated cirrhosis. So I think that is where probably because of the immunosuppression, immunomodulation that is being because of the drugs, I think somewhere the same benefit is extended to patients with autoimmune hepatitis. But we have had patients with autoimmune hepatitis with severe disease like the one which we discussed just now. And with regards to your first question about use of remdesivir in a patient with cirrhosis which is compensated, I think, again, like you said very appropriately, that it has to be with intense monitoring. And after understanding that there is a possibility of a significant benefit, and not just for shortening the duration of the symptoms. So I think only when we find that there is that we are really, it's indicated and there is not much of a choice left, then I would give it, but with intensive monitoring, as you say.
Dr. Anil, you have such a huge experience. What is your policy in your hospital? Dr. Anil, you have to unmute yourself.
Sir, with the intense monitoring, we have used remdesivir in CLD patients. Those are having a normal transaminase, and with intense monitoring, we have used remdesivir in those patients.
So, Ajay, with your permission, should we move on to the third case? We have.
Can we have some questions?
Yes,
comments from Dr. Girish?
I wanted a couple of comments.
I would like to say,
not short over.
Hello.
If you have short over the time, we'll stop. Otherwise, I'll
comment from you and Dr. Girish. One comment from you and Dr. Girish.
Yes. See, as far as our center is concerned, which was dedicated COVID center in Mumbai, and we used to manage at any given time more than 1,100 critical COVID patients. So with this, I would say initially we were not giving remdesivir to any patient with high enzymes and liver dysfunction. But then we started giving with close monitoring, and today we are giving to most of the patients who have high fever on day 7 and those who are requiring oxygen. So these 2 criteria are very important. And if you monitor them, and if it is not rising 3 times above their baseline value, then we can continue with. That is the policy which we are following as far as remdesivir is concerned.
Dr. Girish, what about pirfenidone? Are you a big user of pirfenidone? Because the data is not very sparse, and
Yes.
it is again a hepatotoxic drug.
No. See, actually, that is the post-COVID OPD, which is mainly managed by our pulmonary medicine people, but they also are not giving it much because the side effect profile is not very good. And most of the patient, if you see, sir, that they are recovering well. So whether you give it or you don't give it, the fibrosis will come down over a period of time in most of the patients. That is our observation because they're coming to us regularly for post-COVID follow-up.
Manu, you had something to say?
We'll move. I'll take it the next time, Mahesh.
So with that, we would invite the third presentation from Dr. Ajay Kumar, and the case will be presented by Dr. Anil Vardhani, who is the Director of Internal Medicine at VLK Max Super Specialty Hospital. Dr. Anil.
Good evening, Dr. Goenka. The outset, I am thanks to Dr. Ajay Kumar and Dr. Tandon and Dr. Goenka and Sun Pharma for giving me this opportunity. So I am going to present a capsule of few cases of liver abscess, which is come across in the COVID-19 patients. So how it is significant, they are different from the normal population. Dr. Ajay will give you the further discussion on this, but I am first going to present few cases of liver abscess. So total we have in the last month more than 11 to 12 cases in our IPD department, and so out of them I am going to present few cases. So first is SKG, 55 years old gentleman. This is a known diabetic and admitted on 14th April of the last month and discharged on 28th. And CT severity score was 13. And he received, as per protocol, remdesivir and steroids. But 5 days post-discharge, he developed fever and abdominal pain. And there was a leukocytosis, mild raised transaminase. Yeah. So mildly raised transaminases, and HbA1c is 9.3. This is a moderately poor control diabetic. And ultrasound and the CT is showing liver abscesses, and the total volume of liver abscesses is 244 cc in the segment 3, left lobe of liver. This had focal discontinuity along its left lateral aspect with surrounding perilesional edema, partially exophytic and compressing upon adjacent stomach and G junction. Patient having significant dysphagia for solids. This is a large abscess. Another case is 39 years old female. So again, this is not a diabetic patient. And, he came to me with the history of features of UTI, and later on found to be CVNet positive and treated as a COVID as well as UTI patient. Fever persistent and hence investigated further, and ultrasound and CCT showing the left lobe fourth in the segment of 4B liver abscess and around 58 millimeter volume, volume of 145 cc, and it is communicating in between the liver and first part of the duodenum. So later treated with the endoscopic drainage with few plastic stents in between the first part of the duodenum and the liver. So this is the CT picture of liver abscesses. Now this is the third case, again female diabetic and COVID improving patient, developed fever in 3rd weeks and detected to have right lobe segment 7 liver abscess and another in the segment 6 measuring around 3 by 3.5 centimeter, extending up to the subcapsular location with very thin rim of hepatic parenchyma surrounding them. Treated with all patients treated with IV metrogel and she also had a lower GI bleed, and colonoscopy was done, which is showing the colonic amoebic ulcers. All three patients was, this is the liver abscess. All three patients was investigated, and amoebic serology was positive on all three patients. Thank you.
Stop the screen sharing, Dr. Vardhan. Well, friends, before we open it for discussion, it's a very interesting association that we have seen. So we thought we'll share it and share our thought processes. When we talk about COVID-19 with some additional infections, there are three types of terminologies which are being used. One is co-infections, super-infections, and opportunistic infections. As the terminology itself is very clear, and all of us, just to clarify, that co-infection is a simultaneous infection of the host by two different organisms. And in gastroenterology, we commonly see waterborne infection causing salmonella and waterborne virus hepatitis. And so influenza virus is also known to occur along with co-infection with a number of organisms. While superinfections, which are considered, it's a second infection superimposed on first infection by a different bug. And that usually we all understand those terminologies because of the effect of the drugs, whether it changes the bacterial milieu, or it's which usually can occur with the bacteria, fungal, viruses, and so on. And third is the term called opportunistic infections, and which we'll talk a bit more. If you look at the COVID-19, co-infections and superinfections are well known. And these are commonly seen in hospitalized and severely ill patients. And the people who are deeply involved, all of you are deeply involved in the COVID management, you know that after the second week, that the secondary infections become important. And this is more happens in the ICU setting. This could be nosocomial, or this could be secondary infection because the patient is immune suppressed. And patient is on ventilator and so on. Severe COVID illness, they say the bacterial plus fungal is more than viral. And so that's when we talk about, there's some data on that in the COVID-19 patient. This is another study from China, that severe cases, the bacterial and viral are more common, while in a overall, this is not the situation. And then there's also a split that out of these infections, respiratory infections are the commonest, and then is the bloodstream, and then the urinary tract infections. But when we talk about today's case, why we have presented this case, this is not something, I like to have gain from the experience of the other physicians dealing with this. This is something which touched us only we realized it only during second wave. The first wave, we didn't see, we didn't notice. Even if we had one or two cases, it never came to our notice. That could be a normal thing. So when we talk about opportunistic infection, there has to be an opportunity and there has to be an agent. And opportunity is usually due to weak immune system, and which we all aware of: AIDS, immunosuppressive drugs, altered microbiome, and breached integumentary barriers. While agents, common agents are mentioned here: bacteria, different types. we all know about C. diff, Legionella, the staph and Pseudomonas, and so on. And fungi, there's a big noise around all these fungi across the country. I don't want to get into that part because that's an important thing, of course, but not for today's discussion. So if you look at the parasites, the ones which are mentioned are the Cryptococcus and Toxoplasma. I have searched for the literature. At least I have not come across any mention of a parasite amoeba being presenting as a opportunistic infection. And of course, we all know about cytomegalovirus and polyomavirus, herpes virus, and so on. All these agents may exist as commensals in a healthy person, but in an immune suppressed, they become active. or even otherwise, they may be causing mild infection in a normal immunity person. But in an immune suppressed, the same disease becomes more severe. So this is my just a thought that after looking at so many cases, if you analyze that, I got some data that out of total 1,100 patients admitted in the last 3 months, we have seen in our hospital, we have seen more than 10 patients of proven amoebic liver abscess in this group of patients. We did not come across any reports in the literature. Then we also gone back and looked at how many were the total liver abscesses in the corresponding 3 months in the last year. We didn't find the same number. We found much less number. And I have said here total 9 cases. Actually today morning we were discussing, then we looked at it. Dr. Vardhani brought to my notice few more cases. And so that's number, actually 1 case we diagnosed today itself. And we have not analyzed in great detail, but the usual presentation is at the end of 2 weeks. And we have not noticed that there is any difference in the outcome of COVID or an outcome of a liver abscess, who are usually admitted. A large number of liver abscesses don't get admitted with us. We are treated as an outpatient with a medical treatment. But most of them who get admitted, even without COVID, the outcome of them is almost the same. And so we propose that there is a probable association. Probable, I'm using the word because we need to look at the data more carefully. But we think that there is a more probable association of these patients because of immunosuppression developing opportunistic infection with the Entamoeba histolytica. And all these patients that we are talking about, their amoebic serology was positive. And significant number of them, we have had colonic ulcers. And when I'm mentioning that, I also have not shown that data that there are certain patients, significant number of patients who did not have a liver abscess but had GI symptoms, and they were seen as amoebic ulcers per se, amoebic colitis. So friends, from this presentation, we wanted to just bring it to notice and discussion and share other people's experience. It's a new developing disease. So we'd like to know what is the experience of other physicians, experts in this field. It may be too much that we are reading too much into that, but we thought we'll bring it to the notice of everybody.
I think Manu, you wanted to make some comment. Thank you, Ajay, for a very, very interesting association which you have shown. Possibly this is not discussed at all. Maybe this is a problem of our country, and that's why it has not been highlighted in the Western literature. But let's hear from Manu, who has a huge experience.
Yeah, Ajay, I think that that you compared with 3 months of last year during the same time.
That's right.
Makes it that there is a causal relationship because you didn't have any cases the same time last year.
Yeah, the number was too small. And the total number of non-COVID patients admitted at that time was much higher.
Yes. So that makes it interesting whether you talk of immunity. What is interesting is we as such, whenever we get a liver abscess, amoebic serology per se generally doesn't come positive. So is that COVID has got something specific that it activates a commensal in this bacteria?
But, look, there are different ways of testing amoebic serology. I think we need to check the methodology there.
We have VG Mohan Prasad.
So you think that most of our abscesses are still amoebic? I thought they are mostly mixed.
Yes. VG, you are welcome. You can please join in if you are there. Akash, you have any comment to make? Yeah.
No, sir. No comments.
So I think it's a very interesting association, but we really we can't prove.
Dr. Girish is there. He's a huge experience, one of the largest. Maybe has he noticed any such thing, association?
See, as far as liver abscess is concerned, we don't have that much, like you presented. But similar thing we are observing for these mucor cases. Because last year, hardly we are seeing hundreds of cases of mucormycosis. So with the same, the same COVID, but we don't know whether it's a virus variant which is creating this problem. So from the liver abscess point of view also, are the gastroenterologists feeling that this COVID variant has some role in it? That is my question.
Too early to comment on that. I mean, I think right now we are at a stage where we just noticed this, that there is an increased number, and we are trying to extrapolate it to that it may be associated. That's it.
Okay.
I think at this stage we cannot go beyond that. See, even initially when we saw 2 cases or 3 cases of mucormycosis last year in the first wave. And that we never said it is an association, it was incidental or whatever it is. We never talked about that. But this year it had come like another epidemic, which so it forced us everybody to think that yes, it is has some relationship.
Because I'm saying because we are getting the patients who are non-diabetic also. Non-diabetic and have not received excess steroids. In spite of that, they are getting bad mucormycosis.
Yeah.
So what is the real reason behind it? That is what everybody is thinking. Whether similar thing you're thinking as far as liver abscess are concerned.
Yes, Vijay, you want to add something or anybody else? Otherwise, we can go to the next case. Anybody in the panel? Okay. So, Mahesh, are you ready with the...
So the next case is being presented from Apollo Clinicals, Kolkata, and Dr. Shivraj Aflazpurkar would present the case. He is a final year DNB gastroenterology student. It's a very interesting case, and I would want everybody to look into these 2 short snippets, because we in the last 1 week have surprisingly seen a large number of cases which are similar to this. And I think we need to all look for it. Dr. Shivraj.
Good evening, everybody. My topics today is hemophagocytic lymphohistiocytosis-like syndrome in patients recovering from COVID. I will be presenting 2 interesting cases. My slides are not moving. Yeah. So the first case, on 18th of April 2021, a 49-year-old gentleman with a background illness of hypertension and dyslipidemia presented to us with a history of fever and upper abdominal pain for 3 days. And on evaluation, he had COVID-19 infection, which was RT-PCR positive. And it was a mild disease, CT severity index of 4/25. And he was admitted in COVID general wards. On investigation, his hemoglobin was 14.2 and leukocyte counts were 16,900 and total bilirubin was 3. AST, ALT and alkaline phosphatase was 55, 80 and 328 respectively. And CT showed 3 hypodense lesions, largest measuring 4 centimeter, and 1 hypodense lesion in the lateral side had a concentric collection beside it, which is suggestive of a ruptured liver abscess. So the liver abscess was drained. Along with that, he was treated with antibiotics and supportive medications. Patients, since he had only mild infection, only supportive treatment was given for COVID. Patient developed COVID antibodies in 2 weeks, and then he was shifted to gastro wards. Patient had persistent fever and tachycardia even after 2 days of when he was shifted to us. And when we repeated the imaging, it showed a residual liver abscess, which was drained. And later on, due to persistent fever and tachycardia, we had done some inflammatory markers, which showed CRP of 2 milligram per liter. IL-6 was 91. Ferritin was 26,353. Triglycerides were 356. Fibrinogen was 352. And platelet count, which was initially normal, dropped down to 90,000, which was initially 1.52 lakhs. So in view of high fever, high ferritin, increased triglycerides and thrombocytopenia, which we thought it would be a Hll syndrome or mimicking any syndrome mimicking like HLH, we treated with IV dexamethasone for 2 days. And then on the 3rd day, when we repeated his blood parameters, which improved, and also he was symptomatically better. And we tapered the steroid in 10 days and the patient was discharged. And on follow-up after 2 weeks, patient was symptomatic. Coming to the second case, a 41-year-old gentleman with no comorbidities. He had recovered from severe COVID-19 disease, that is CT severity of 18/25, and which was diagnosed 3 weeks prior to the disease. On the right-hand side, you can see the CT image of his patient with 3 weeks prior to this admission, which showed bilateral lower lobe ground glass opacities with loss of architecture. Now, this time he was admitted to us for high-grade fever and raised transaminases. In the present admission, his leukocyte count were 1,000 with neutrophils of 70% and lymphocytes of 30%, and platelets were 1 lakh. AST was 2,302, ALT was 1,832, and alkaline phosphatase was 286. On examination, his GCS was 15. He had tachycardia, blood pressure was normal, respiratory rate was 24 per minute. On systemic examination, only had tachycardia on cardiovascular system examination, and abdomen was soft, non-tender, no organomegaly. CNS was normal. There was no neurodeficit, and he had only tachypnea on respiratory system examination. There was no added sounds. So we went ahead and evaluated in detail. His anti-HEV IgM was reactive. HAV, HBsAg, anti-HCV were negative. And he USG showed only grade 1 fatty liver. On endoscopy, only small varices were seen. And we went ahead and evaluated with other autoimmune markers which were negative. IgG was normal and ceruloplasmin was normal. Patient had persistently high-grade fever, due to which we thought we will evaluate further with inflammatory markers in view of high-grade fever and bicytopenia. So we thought of working out for secondary HLH. His CRP was 10.8, IL-6 was 160, ferritin had shot up to 96,750, fibrinogen was normal, D-dimer was 17,000, triglycerides were 247, CMV, HSV, and EBV workup was negative. We did a bone marrow aspiration which showed hypocellular marrow. There were no hemophagocytes. Sputum culture showed Pseudomonas aeruginosa, which was sensitive to most of the antibiotics. Blood culture was sterile and urine culture was also sterile. Patient he had a very high H score. So patient had HLH-like features, but it was not fitting into HLH. In view of high H score and multi-system inflammatory features, immunoglobulin was started, but patient deteriorated rapidly in spite of this treatment. He had respiratory failure, so we stepped up from HFNO to mechanical ventilation. He had a refractory shock, high-dose inotropes were given, noradrenaline vasopressin, and renal impairment. For that, we started a continuous renal replacement therapy. After 4 days, patient expired. That is just 2 days back. So during our treatment of these two cases, especially the second case, we had several things in our mind. Could this be a Hll syndrome, which is the main core issue in the severe COVID-19 cases? In the second case, almost 4 parameters out of 5 were fitting. Or it is just a macrophage activation syndrome and COVID-19, because all the parameters are not fitting into Hll syndrome. The next closest DD would be the macrophage activation syndrome. Or it is the so-called multi-system inflammatory syndrome in adults with SARS-CoV-2 infection, which is considered as another piece of an expanding puzzle. This was initially described in children. Now it is almost commonly seen in adults, which is called as MSA adults, or it is just the hyperferritinemia in critically ill patients, which is still, there are 2 schools of thoughts whether the ferritin itself is a product of inflammation or it is a pathogenic mediator, or it is simple COVID-related acute and chronic liver failure, which fits in Hlh criteria of ACLF. Coming to H score, which is whenever we keep HLH as a differential diagnosis, we calculate the H score. H score of 169 provides a sensitivity of 93% in diagnosing HLH. So if the patient has known underlying immunosuppression, then if 18 points will be given, no, then 0 points. Similarly, temperature 33 or temperature 38.4 to 39, then 33 points, more than 39.4 degrees Celsius, 49 points. Organomegaly for hepatomegaly or splenomegaly, 23 points. If both are present, 38 points. Number of cytopenias, 2 lineages, 24 points, 3 lineages, 34 points. Similarly, ferritin of less than 2,000, 6,000, more than 6,000, 0, 35 or 50 points are given. For triglycerides in millimoles per liter, if it is 1.5 to 4 millimoles, 44 points, and more than 4 millimoles, 64 points. And fibrinogen, if it is low, 30 points are given. And aspartate aminotransferase, if it is more than 30, then 19 points are given. Similarly, so based on this calculation, for patient 1 had H score of 216 and patient 2 had H score of 190. But these 2 patients were not fitting into Hlh criteria. Hlh criteria, which is a traditional 2004 criteria, which says at least 5 of the following should be present: fever of more than 38.5, splenomegaly, cytopenia affecting at least 2 cell lines like hemoglobin less than 9, platelets less than 1 lakh, absolute neutrophil count less than 1,000, or hypertriglyceridemia or hypofibrinogenemia or hyperferritinemia. The other tests are on liver, on bone marrow biopsy. There should be hemophagocytes either in the bone marrow or spleen, lymph node, or liver. Low or absent natural killer cell activity and soluble CD25 elevated, which is more than 2,400. So these the below 3 parameters are very difficult to do. So for this, there is a modified criteria called Hlh 2009 criteria, which I have not shown here because most of them still follow Hlh 2004 criteria. So there are several case series we went through of severe COVID-19 patients with secondary HLH in one of the largest case series from Greece, where 8 patients were included. All had acute respiratory failure with PO2 by FiO2 less than 100. They had calculated H score, which all the patients had at least 169 or more, and 7 patients were admitted in ICU. For them, they gave intravenous anakinra 200 mg every 8 hourly for 7 days. And 1 patient was admitted in general ward. They gave intravenous anakinra 300 mg once daily for 7 days. So the main benefits they observed were at the end of the treatment, there was less need for vasopressors, improved respiratory function, and lower H score. Although 3 patients died in this series, they say the mortality was lower than the historical series of secondary HLH and sepsis without COVID-19. Coming to multisystem inflammatory syndrome in adults, which is recently defined by CDC, which is the MISA associated with SARS-CoV-2 infection. The age for adults, the age group, it should belong to more than equal to 21. There is no comment on fever. However, in children, the patient should have high-grade fever, and there should be laboratory evidence of inflammation. Patient should be hospitalized, and number of organ system involved should be 1 or more. And mainly the organ system which are named are hypotension or shock, cardiac, thrombosis, thromboembolism, and acute liver injury. And there should be exclusion of other causes, that is exclusion of severe respiratory illness, because they say if patient has severe respiratory illness, tissue hypoxia can itself cause multi-organ failure. And the patient should have one of the tests positive for COVID, that is RT-PCR or antigen or serology within the past 12 weeks of this presentation. And there need not be any COVID-19 epidemiological link. Our patient had all of these features, except that on presentation, he had no severe respiratory illness, but as the disease progressed, after 2 days, patient developed severe respiratory illness, and he was intubated. So again, it is not completely fitting into this criteria. Coming to COVID-19 and acute and chronic liver failure by easily.
1 more minute.
Yes, last slide. So the patient fitted into ACLF criteria. There are large-scale studies from China which showed 2 to 11% of COVID-19 patients had pre-existing liver disease. Patients with ACLF are more prone to develop severe COVID-19 illness. Most of the series have shown that there is higher mortality in ACLF patients with pre-existing cirrhosis. There are multi-center studies and one study from AIG as well, which showed mortality from 30 to 55%. Thank you.
Thank you, Shivraj. So I think we presented this case primarily because in the second wave, we are in the last 1 week seeing a lot of patients of this manifestation. They come back towards after the 3rd week, they have either continuing fever.
Mahesh, lost your voice.
Lost its connection. Yeah, I think he's back.
And the video. Mohan, welcome.
Yeah, hi Manu. Hi.
Mahesh, you've lost your voice. Can you hear us?
He's come back. Voice is gone, Mahesh. Voice.
Hello?
No voice.
Can you hear me?
Yes.
Now, yes.
I said we are seeing these cases more and more, and we have at least 3 more patients admitted with us. I think it's a spectrum, but one of them, yesterday we did a bone marrow, 32 years old male who was recovering from COVID 4th week, and we find him classical Hll syndrome. There's a difficult disease to treat. So we thought we'll bring that to this panelists. Any question or comments?
Yes.
Akash?
Mahesh?
Yes.
Can I? Akash, yes, then I'll speak something. Akash, after you.
No, sir, I think excellent cases, I think, to highlight the points and very well presented. My question is, if you diagnose them as probable HLH, would you tend to use IVIG in these patients? Because I did not find any literature in HLH due to COVID treated with IVIG. So, I mean, your thoughts on that?
If I can answer that, we have a very small series of HLH complicating COVID. So people have tried anakinra, but we have in both the cases which the second case which we presented, we used IVIG. And we used almost 2 grams of IVIG over a period of 3 days. And the case which I'm talking about today, which has been proven to be Hll syndrome, 32 years old male, we are using IVIG as well in that particular patient. So the steroid along with IVIG is the first treatment. Then people have tried various drugs, including plasmapheresis has been tried. I think there's a very, very difficult patient because the patient's relatives feel that they are now coming out, third week is gone, they are fine. So, and then suddenly this cytokine burst like thing comes, and we find in the second case which Shivraj presented, initially we were fooled. We thought anti-HEV IgM positive, and we thought it was accidental hepatitis E complicating a recovering COVID. So we didn't do anything in the first 2 days. But then the enzymes started going from hundreds to 1,000 to 3,500. And at that stage, we start looking for ferritin and D-dimer, and we find everything is coming back. Almost 1 lakh was the ferritin level. So I think we lost this second man. We hope that the third man, which I'm talking about, who is now struggling in our ICU, we are able to survive him. But it's a time to learn new manifestations, new complications, and we have 2 more patients who are not so sick. So I think this is a syndrome which we're going to see more and more, and this may again be Indian strain, so-called Indian strain, which may be manifesting in the second wave.
It will be very interesting to wait for the NK cell activity to recur, to come back. It will be very, very interesting to study that, seriously.
We have sent that in the second case. Let's see.
Yes, Manu?
Just our experience, he has of course mentioned, we have published, we have had a spate of HLH. Not all of them were COVID. Some were sepsis of other cause. I wanted to make a comment. As Mahesh has said, we have also used etoposide. One of them we are priming for bone marrow, but none of them are doing well. So I think, it's really, as Mahesh has just pointed out, tough situation with or without COVID, HLH, steroids, pulse, and high doses, etoposide, immunoglobulin, still waiting. Lost some.
I just want to, if any point on this case, then I'll stop here. Otherwise, I just want to add regarding my previous case.
Dr. Anil, Dr. Girish, you have anything to add?
Sir, we have not come. I'm Dr. Vardhani, sir, Anil.
Yes.
Yes,
we
Doctor.
have not come across at this time HLH patients, but last year, not in COVID, with other, because in Delhi, lot of dengue and other viral diseases are very common, and we come across very routinely HLH patients. Most of them are secondary HLH, and they are very difficult to treat, and we are having the facility of plasmapheresis, and we are doing plasmapheresis in most of the cases. Yeah.
VG, you have anything to add? I think this is a situation where we should be looking for. Even the first case when we diagnosed, we were surprised to find that. But then in the last 1 week, we have diagnosed 5 similar cases. They may not be fulfilling all the criteria of Hll syndrome. They behave like Hll syndrome. So Ajay, you have something to add?
Yes, really, thanks for bringing out such an interesting thing. And I think all of us will be on the lookout for this. Maybe we are missing these things. Manu, you don't go anywhere just because what happened is in between, I had a phone call from Nagi, so I discussed about the liver abscess part to him. And he said they have seen the 4 cases in the new hospital of a liver abscess, a maybe liver abscess in the COVID patients. So voice is coming up, and they have drained it. They have so it's not is a isolated thing. So probably the things are coming. Manu Nagi just now told me that they have seen 4 cases in the new center. Just now,
I told you even HLH, because we are seeing them in the new hospital. That's where we admit our COVID patients. We shift from this place to that. So we've seen both HLH and this, and we have seen them in non-COVID also, HLH especially, including the bone marrow.
Ajay, the first case which Shivraj presented had liver abscess again. So I think we also seeing it not as much as you are seeing, but the first case actually was a liver abscess. And when the fever continued to be
2 liver abscesses, there were 2 of them.
3 of them. And so when the fever recurred, we thought it's a liver abscess which is residual. So we asked our intervention radiologist to again aspirate. She aspirated once more, but this time she found nothing. And so we started looking for an additional cause of fever.
Okay. Do we go to the last?
With that, we will move on to Coimbatore. And Dr. Ashish will be presenting the case, I suppose. And we have Dr. Ashish Khattar, who is from Venkateshwara Hospital. And this will be dealt by Dr. V.G. Mohan Prasad, who is the chairman of VGM Hospital, Coimbatore. This is the last case, and after that, I have a 7 minutes presentation on vaccines. This was suggested by Ajay, and so I prepared a small presentation which I'll discuss at the end. So, Dr. Ashish.
Thanks, Mahesh. I will request Ashish to. Now, I will share the screen. I'll project the slides from here so that he can take over. So please permit me to do that.
Good evening, sir, and respected seniors. I am Dr. Ashish. I work as a senior consultant in Venkateshwar Hospital, Delhi. We have been seeing tremendous amount of COVID cases from the last year itself. The hospital this time reached to an occupancy of almost 350 patients of COVID, and we have seen enormous presentation of COVID patients, both GI, non-GI, respiratory. Definitely there are symptoms, and now the endocrinological manifestations also, which are turning a lot. That I'm going to share a few my thoughts on that after this case. So we are discussing these two cases from SIR's center, right? So the first case is a 58-year-old male and retired government official, right? He presented with us with complaints of loose stool since last 15 days, 4 to 5 episodes per day. The stool was green colored, not blood tinged, almost 200 ml per episode, and associated with rubbling and nausea and loss of appetite, right? There was no history of any fever, no breathlessness, no body pains, no bloating or vomiting. He's not a known case of any diabetes, hypertension, or any other comorbidities. There is no significant past history, and there is no similar history of such episodes in past. So medication, what he had received, he was treated initially by his family physician, and he took rifaximin, cefixime for 3 days, following which the diarrhea temporarily regressed, and he had recurrence of symptoms after 3 days of therapy again. Diarrhea continued. Then he received gentamicin injection, and he was continued on rifaximin. However, he continued to have symptoms. The COVID PCR done for the first time was found negative. Next slide. On online exam, day 7 to 10 on the teleconsultation, he appeared moderately built and nourished. There was no sign of any pallor, cyanosis, or clubbing as was shown by the patient. Saturation was 96% on room air. There was still persistence of symptoms of diarrhea, which was on and off. There was no fever. Repeat COVID PCR was also negative. He was added mebavirin and pre-probiotics, and he was continued on rifaximin. Day 11 and 14, he persisted to develop symptoms of diarrhea, and there was no fever. Repeat COVID was again negative. Day 15, previously done all the 4 nasal swab tests over 15 days for COVID were negative. He gradually developed anosmia and change in taste, and said bitter taste actually. Repeat COVID PCR that time was found positive. So he was home quarantined and domiciliary treatment was given. Bovine Colostrum was used, and 25 grams daily for 7 consecutive days was given. He had symptomatic improvement, and diarrhea stopped after 3 days. So he had almost 2 episodes following which was brownish. Feripera 400 mg was given. Initial first day he was given 1600 mg twice daily. That was 3200 mg, and then 800 mg followed by that the standard dose. Right. So CT was done, which showed a CT severity score of 1/25 on day 16th. And a CT severity score of 4/20, 5 days post the first CT. So there was 5.71% of patchy ground glass opacities. Day 20, he was again reviewed online. Anosmia was still there. Taste had become better, and there was no GI or respiratory symptoms. Family history COVID PCR was positive for wife, son, and daughter, done on 14 days back. Next slide. So that was the first case in which we had a 52-year-old gentleman who was moderately built and nourished, and there was no significant illnesses in past. There was no comorbidities, and majorly he presented with us with complaint of loose stools. There was no other illness. There was no breathlessness. Loose stool kept on persistent, and his 4 COVID PCR were negative at a stretch over an interval of 3 to 4 days, done over a period of 15 days. Gradually, when he lost his smell and he had taste alteration, again a COVID was done, which was found positive. And later on, he was given bovine colostrum, and he recovered well, and he symptomatically improved. Family members were also tested positive. We will have a short discussion after the second case presentation from the same. Case 2, he's a 36-year-old male and a doctor by profession. Presenting complaints, loose stool, 15 days history, 4 to 5 episodes per day, greenish color, non-blood tinged, almost 200 ml per episode. Rumbling was present. There was nausea, loss of appetite. Next slide. So presenting complaints, basically fever with chills, loose stools, and since 5 days. Frothy, non-blood mixed stools, 500 ml per episode. Associated rumbling was present. Intense malaise since 2 days. History of parosmia was there. So there was no history of any breathlessness, no body pains, no bloating or vomiting, not a known case of diabetes or systemic hypertension. Past history, no similar history in past. Medication history, he was initially treated again with cefixime and again probiotics and antipyretics. However, diarrhea was persistent irrespective of the symptomatic management. There were few lab investigations which were available. So hemoglobin, if we see, is almost the same from day 5 to day 9, whereas the TLC count had increased from 6,700 to 12,100. Platelets are almost same, 2.76 lakhs initially to 3.3 lakhs on day 9. CRP was initially 10, day 7 was 6, and again day 9 it was 5. D-dimer values, first two values were found normal. LDH was slightly raised, which was 324 on day 5 and 342 on day 7. CT chest was showed normal. Blood the sugars were normal. Ferritin was 69.4 and 67. IL-6 were initially 8.7, which gradually settled on day 7, which was 2.3. Next. So in hospital, he developed postural symptoms and hypotension. He was managed with IV fluids. He had persistence of diarrhea. Nasal swab turned out positive. He was started on remdesivir, steroids, and anticoagulants. Probiotics were continued. However, diarrhea still persistent. And again, bovine colostrum 25 grams twice daily for 2 days, and then OD for 3 days was given. He had good response within 24 hours, and diarrhea stopped in 48 hours, and gradually the BP also normalized. Right. So these are two short cases from Sir's center where the bovine colostrum helped the patients in recovering from diarrhea. And majorly in my practice, when I'm seeing COVID patients, 90% definitely present with respiratory symptoms where the CT have gone wrong. The few asymptomatic patients are there at home with anosmia and parosmia. Recently, we have started discovering in the post-COVID symptoms many patients presenting with hypoglycemia at home. We have been getting calls where the sugars have fallen down with 67, 60 with the episodes of sweating. We have investigated with the insulin levels and things, and the insulin levels were found high. That's particularly the PP insulin levels. The antibodies done for the insulin were also found negative. The endocrinologist was also enrolled on. These were the two short cases we saw today in the hospital also where the sugars had actually fallen down. So I don't know whether anybody else has also witnessed the same scenario in their practice, but few concerns with this COVID virus from top to bottom of the body. Many concerns have been there and affecting everything. Now patients, those who have received steroids, had started complaining of ophthalmic complications with rise in the pressures and retina complications that have also turned up to in the OPD. So I think we can have a short discussion on these two cases and following everyone's experience on what they have witnessed in the post-COVID era and the post-COVID implications, what the patients have been presented.
Thanks, Ashish, for that beautiful presentation. He's our good friend from KMC Manipal, doing a fantastic COVID work in Delhi at this point of time, morning to night, non-stop, more than 16 hours a day. He's seeing only COVID patients. So I request.
What's the relation between VG Mohan Prasad from Coimbatore and Dr. Ashish from Delhi?
My daughter and he are good friends and colleagues and classmates in KMC Manipal. So I requested him to present it because he's been.
I was a little confused that did I write wrong? Anyway. So okay. Thank you very much, VG. I didn't know that there is a separate link and there are at least 100 questions which have come from the various cities.
Mahesh, can I take 5 minutes to?
You have 3 minutes, VG, 3 minutes.
3 minutes, okay. Okay, all right. I thought 5 minutes. Yeah. Okay, just hold on 1 minute. I'll just share my screen. Because this is very important that we need to understand the importance of this problem. 1 second. So,
Really finds bovine colostrum as a treatment for diarrhea.
I'll show you. I'll show you some evidence on that. So I'm
Yeah,
sorry.
for
I'm
me it
just
is news.
still open this. Yeah, my
I mean,
presentation.
that is news. COVID or no
share
COVID, we can use
my
it.
VG is always newsmaker, you know.
Yeah, I
Yeah,
mean,
okay.
he's an international figure. So national, I told you, from Coimbatore to Delhi is child's play for him.
Yeah, wow. Look at that. So thank you, because we don't have DNB program there in our hospital as yet. So, okay. So I'm talking about the diagnostic dilemma and the treatment conundrum in the GI presentation of COVID-19. Ours is a garden variety case that many people will be seeing. So but it's of paramount importance to understand in this COVID pandemic era that because of the ACE2 receptors, which are present right from oral cavity, tongue to esophagus to ileum to colon, SARS-CoV-2 affects and produces an inflammatory process in the GI tract. So fecal calprotectin goes up, and it goes up and persists even after the diarrhea has ceased. So one should not get confused about Crohn's disease or something else there. And fecal calprotectin levels correlated with IL-6. And here the GI manifestations commonly we see are diarrhea, vomiting, and abdominal pain. And COVID-19 is seen in anorectal swabs and stool samples despite the virus disappearing in the upper respiratory tract. So, and 53% were positive for COVID-19 in stool for 1 to 12 days, and 23% persistently were positive in the stool even after a negative PCR. And people have shown that, diarrhea was by far the commonest, 2 to 10%, nausea and vomiting in 1 to 3.6%, and GI symptoms may be a presenting feature of COVID-19 infection, as we showcased in the past 2 cases, and a high index of suspicion is required to diagnose COVID-19 early in patients at risk for developing GI symptoms. Incidence of GI manifestations is higher in the later stage of COVID-19 pandemic than the first stage. And GI symptoms, that this is our experience also. In the first wave, we didn't see so many GI patients, but right now, so many patients with dyspepsia presentation are all turning COVID-19 positive. And GI symptoms in severely affected patients were higher than in the non-severe patients. This is of paramount importance to understand. See, this study also shows that abdomen pain can occur as a characteristic of severe COVID-19. And so ensuring safety of endoscopy team is of paramount importance, because you might be investigating for pain or hematemesis or some other problem. Then we should make sure that they are screened properly before subjecting them. So pre-screening for COVID-19 and proper infection control protocols have to be followed to protect the health of the GI team during risky procedures. So this is important because most of the GI manifestation patients had no respiratory symptoms at the time of referral. They were totally unaware of their COVID infection. These patients were carriers of the disease during the onset of their symptoms. During this pandemic, incidence of GI symptoms should prompt for testing for COVID-19, as a timely diagnosis can play a significant role in controlling the spread of the virus. As I told you, the RNA shedding goes on from 70 to 126 days after an episode of COVID. And when compared to SARS-CoV-1 and MERS, you see the viral load that is shed is very high. And mucosal damage in the esophagus and intestine can produce ulcers and can produce hemorrhages. And the GI manifestations have to be tested. And look at this, patients presenting with GI symptoms on admission showed a higher risk of complications of ARDS, acute cardiac injury, AKI, ICU admission, and high mortality. And these are all other GI manifestations. All these can happen, but majority are these. And hematemesis, of course, these are esophageal ulcers which are bled. And this is important because the SARS-CoV-2 disrupts the integrity of the gut mucosal barrier and makes it a leaky gut. And so this persistence of dysbiosis happens even 30 days after the COVID clearance. So there is something called now a new terminology, post-COVID GI functional disorder. So which should fulfill the Rome 4 criteria, and it should not have existed before the diagnosis of COVID-19. So use of bovine colostrum has been found to be useful. This is philosophy, but there are beautiful studies which are shown. Look at the study. The cow colostrum promotes early recovery. It's a beautiful, prospective, open label, randomized control trial. 200 COVID patients, 100 were put on standard of care, 100 were put on standard of care plus colostrum. And they look at these results. In the mild cases, number of days required for cure was much, lower in the mild, the colostrum group, the blue group, and again, moderate group also, everything improved in the colostrum group, and the severe group also, everything improved. So they showed fantastic results, and cow colostrum food supplement, because only a nutrition supplement, it's not a pharmacologic agent, may be beneficial in COVID-19 patients for early recovery in mild, moderate, and severe categories. This is from our own country, a beautifully done study from Maharashtra showed that. To conclude, GI manifestations are an important feature in some COVID-19 patients. The significance of GI symptoms in clinical practice should not be underestimated. GI symptoms in COVID-19 are more insidious than respiratory symptoms, making them easy to overlook. However, some patients might have only GI symptoms during the whole course of the disease. Some continue to shed the virus in feces despite respiratory samples testing negative. Understanding the varied susceptibility of an individual GI symptom to SARS-CoV-2 will promote the personalized COVID-19 therapy during the present pandemic. Testing patients with GI symptoms for SARS-CoV-2 should be considered, irrespective of them not having other typical symptoms of COVID-19, because they will act as carriers forever. So for long periods, transmitting to others. This is exactly what we wanted to convey. So thank you so much.
Thank you, VG, for some very interesting data, which possibly we can discuss for a long time, but time doesn't permit that. So we have only about 15 minutes left. I would, with Ajay's permission, divide into two parts. There are about 50 to 60 questions on the chat box. I've just selected 7 or 8, which are very relevant to today's discussion. But before that, can I have 5 minutes to just talk about the vaccination on about 10 slides? So
yes, please go ahead.
So I think I was told that since the physicians would be there, I must talk a little bit about the vaccination. So let me just touch upon some of the important aspects of vaccination. And like our knowledge of COVID, our knowledge of vaccine is also very dynamic, and we are changing our approach to vaccination. What are the aims of vaccination? Aim of vaccination, of course, is to prevent infection, but more important than that is to prevent severe disease. And why we may not be able to prevent infection in all cases after vaccination, there is a good literature to say that severe disease is, if not totally prevented, at least reduced to a great degree. And finally, by vaccination and by natural infection, if you can reach a herd immunity of about 70% having antibody, the job will be done. So where do we stand about I think we have all seen this picture, and it's become an irritation that for the last 16 months or so, we are seeing this picture, and we all understand the importance of spike protein now. So the vaccine strategies can be basically divided into five types of strategies. One is live attenuated virus, but in a pandemic like this is not being used for corona. So live attenuated virus is not used for corona. So the one which can be used is inactivated virus, so that you have a virus which is inactivated, usually chemically, and this inactivated virus is then introduced by means of vaccine and produces the antibody to the spike protein. We also know that there is what is known as mRNA protein, a vaccine in which you extract mRNA from the virus and then introduce the mRNA into the body, and then the antibody forms against the mRNA. We have then vector-associated vaccines in which we extract RNA, convert into DNA, and then this is associated with the vector, which is usually an adenovirus, which is then injected into the body to produce the antibody. And finally, we have protein subunits, small subunits which can be just a spike protein, which is introduced and produces the antibody. So these are the 5 types of vaccines which are possible. And this is not done in the COVID pandemic because it's very risky. This is what we know as Covaxin, which is an inactivated virus. We have mRNA, which is Pfizer, Moderna, and now Zydus is trying to develop one. We have Covishield and Sputnik from Russia, which are vector-associated The Covishield has a chimpanzee vaccine, adenovirus, whereas Sputnik has human adenovirus. And we have trials going on with Novavax, which is protein subunits. So these are 5 types of vaccines, which are the strategies. If you look at the Indian and the world scenario as of today morning, this is the scenario in the world. 181 crores of vaccine doses has been given, which only, and the 2 doses, if you look, it only covers 5.3% of the population of the world. This ratio is 40.4% for United States. So that 40.4% of the United States is covered by vaccine as compared to 3.1% in India. It's the sheer delay which was there initially, and now because of the population coverage that we are lagging behind. This is the total doses of vaccine given in the various countries. And you look at the Indian scenario. So if you look at the Indian scenario, some of the states have done very well. Gujarat, Karnataka, Maharashtra, Rajasthan, Uttar Pradesh, and to some extent West Bengal, that a considerable percentage of population received the vaccine. So let's look at the 4 types of vaccines which are available: messenger RNA vaccine, mRNA, inactivated vaccine, subunit vaccine, and viral vector. What I want to tell you is that they have all been developed very rapidly. If you look at immunogenicity of the vaccine, it is possibly the best for mRNA vaccine, 95%. For Covishield, it is 77%. For Sputnik V, it's 92%. There are some of the other examples of vaccines being used in the various patterns. These are the vaccines which I talked about. Now, the important difference is the storage. Covishield has to be stored at 2 to 8 degrees. So is the inactivated vaccine. However, for Sputnik, you require minus 18 degrees, which can be a challenge. And for messenger RNA vaccines, you require minus 20 to minus 80 degrees centigrade, which can be difficult for a country like India. Now, when you give the first dose of vaccine, the immune response is there after 14 days, but it's not very strong and it falls till you give the second dose. And then at the second dose, you find a secondary immune response, which may vary from 2 weeks to 4 weeks, and this response is larger and longer. Now, what is vaccine efficacy? It's attack rate in non-vaccinated minus attack rate in vaccinated. This will be, I'm sorry for this mistake, divided by attack rate in unvaccinated multiplied by 100. Now, this is an important data which has changed our approach to giving Covishield. Initially, when we doctors received Covishield, we got it within 4 weeks, the second dose. But this study has shown that possibly that was wrong. And giving the vaccine, the second dose of Oxford vaccine or the Covishield vaccine should be given the second dose at more than 12 weeks with the efficacy of 81.3% compared with only 55% if it's given less than 6 weeks. Now, this is a very interesting trial with Covaxin, which has shown that while Covaxin has an efficacy of 78% for reduction in cases, almost 100% it reduces the severe cases. So that's what we want, that at least the severe cases should be reduced. What about comparison in terms of age? Most of the vaccines are for more than 18 years, except the Pfizer vaccine can be given for 12 years to 18 years as well. There's a trial going on with Covishield with younger age. What about the doses? Most of the vaccine requires 2 doses, except Janssen's vaccine, which is for 1 dose, but there are some issues with Janssen vaccine. Sputnik has come out with a new vaccine, which they call it Sputnik Light, which will have a single dose vaccine yet to be available in India. Interval, we know that for Pfizer vaccine, Sputnik, it's 3 weeks. For Covaxin, it's 4 to 6 weeks. For Moderna, it's 4 weeks. And Covishield now is 12 weeks plus. And this is the cost which I have mentioned. So whom to give? Universal, if you can. But the priority should be for IBD patients, liver disease, immunosuppressed, organ failure, transplant recipient. You can give the vaccines to patients who are anticoagulation and antiplatelets, and also in immunosuppressants, though people who are on high immunosuppressants, if you can avoid it during the active phase, it's always good. Contraindication will be those who have anaphylaxis, reactions to the previous dose of vaccine, those who have high fever. At this moment, the Indian vaccine is not allowed for pregnant people, though there are trials going on. But the Pfizer and the Moderna vaccine can be given to the pregnant ladies. You should defer vaccine for those who have received convalescent plasma, those who have received monoclonal antibody, those who have been infected with COVID. This period has varied. Initially, we thought 4 to 8 weeks, but now the government instructions are that for somebody who's recovering from COVID, you should not give a vaccine for first 3 months. There's some evidence that those who has received liver transplant, you should delay the vaccine by 90 days. Side effects, hardly any. I will not get into that. But some of the serious side effects can be anaphylaxis, and some of the vaccines can cause thrombosis and thrombocytopenia. Now, interestingly, we have now this Indian dual mutant, which is B1617, but both Covaxin and Covishield are effective against this, though to a smaller percentage than compared to the wild vaccine. It has been shown in a recent trial that Pfizer vaccine is very effective against Indian strain, almost 90% compared to 60% for Covishield. That's it. I wanted to share. If there are any questions, I'll be happy to take it. Otherwise, we can take up some of the questions. Ajay, Manu, Akash, any comment?
No, what you rightly have pointed out that we should insist on anyone we contact, it's universal vaccine. The chances of anaphylaxis is almost zero. The thing is, I had only... Okay, go ahead, Ajay.
There are a lot of questions which come from the patients of IBD on immunosuppressants, on biologicals, cirrhotics. Actually, that's the point that I was, or the patients with the cirrhosis, or the patients on immunosuppressants, steroids for autoimmune hepatitis, and so on. And my common question that every day, I have patients who have undergone liver transplant on follow-up. So anybody who's asked this question, the answer is they must have vaccine. See, all these immunosuppressants and have patients who are on immunosuppressants can have a low response to vaccine, but at the same time, it is not contraindicated. So that's the point which needs to pass through everybody, because every day we get patients inquiring about this. At least I get 2 or 3 phone calls every day. Can I have the vaccine? Can I have a vaccine? The message is that everybody, except for the known allergic reactions to certain things, otherwise everybody must have this thing. The only thing that we like to restress, yes, these medicines can decrease the response to the vaccine, but it is not useless. It's not contraindicated.
Yes, Partho, you have one comment?
Sir, you told about the Covishield vaccine. The recommendation is if it is more than given more 12 weeks gap, the immunogenicity is higher. But in IBD patients who are on infliximab, it has been some studies are there who have shown that if the immunogenicity of the vaccines are little less, and if you give the 2 vaccines little bit within the 8 weeks, then maybe the immunogenicity is better.
I think you raised a very important point. That's a small subgroup. So maybe at that stage, you can possibly give Covaxin as a preferred vaccine in that situation. I think that will solve the issue, because now you cannot take the second dose officially. COVID app will not allow you to register yourself for the second dose before 84 days.
Before 84 days. Yes.
So I have Sun Pharma is very, very keen, and I also think that this will be injustice that if we don't take any questions. For the next 5 minutes, Ajay, can we just take up some of the questions? And I have categorized these questions into those which are related to liver and GI tract, luminal. So one question is there a terminology called IBS, post-COVID IBS? I think VG Mohan Prasad briefly mentioned about it. The second question is there a role for BSL-3 or probiotics in the management of COVID? And third is what's the mechanism of diarrhea? So can we have one-line answers from Ajay and VG Mohan Prasad on these? Is there an entity called post-COVID IBS?
Yes, I spoke about that. So that is being defined now. And the second answer,
probiotics.
Pre-probiotics, as you saw in both our cases, they were all on pre-probiotics. Nothing worked. Even rifaximin didn't work. Antibiotics didn't work. So we needed to strengthen the gut mucosal barrier. I'd seen this article, so I just tried the bovine colostrum. Immediately it responded. So that is something interesting.
What about diarrhea? Is the mechanism of diarrhea is because of the AC receptors or is because of the gastric secretion?
Yeah, both. What happens is the ACE2 receptor that is there in all along the small bowel and large bowel, and as the virus enters there, it produces loosening of the tight junctions. I showed you the cartoon where it produces inflammation there. Number 2, it just produces a bacterial dysbiosis because of lack of time.
Thank you, VG. Is there a role for PCP prophylaxis in COVID patients? That was the question. Dr. Anil Vardhani, anybody would want to take that? PCP, pneumocystis carinii prophylaxis.
Prophylaxis for whom?
For anybody who is suffering from severe COVID, should we give PCP prophylaxis? I think there's no guideline.
No proven data. No proven data on that, Mahesh.
Ajay, there was a question of high D-dimer in patient with ALA. Will you still aspirate or put a drain?
Say it again. Say it again.
High D-dimer, which is a component of COVID.
Yes.
So somebody who has amoebic liver abscess and high D-dimer,
Yes.
will you still aspirate or put a catheter?
Yes, I won't be, whatever the clinical condition demands, we'll do it. It's not a contraindication, that angle. It's
So
what the patient's clinical demand is.
There's a couple of questions again on Gilead. That is a Gilead hepatotoxic. I personally feel that if it's not in a controlled dose, it is a potentially hepatotoxic drug. Akash?
Sir, actually, the Tinospora is supposed to be hepatoprotective. But as you very rightly said, in inappropriate doses or in patients who have a predisposition to autoimmune disorders, it can unmask autoimmune hepatitis. And we have just collected data on 60 patients from 6 different centers who have had Gilead-induced secondary autoimmune hepatitis.
So do you know the dose which was taken in these people? Is there any way you can know the dose?
Sir, we are actually trying to analyze the dosage. But we don't have dosage available for each one of them because the concentration is not known.
Yes. It's almost impossible to get the dosage. We tried it 3 of our patients. It's almost impossible.
Akash, there is a specific question to you. Pirfenidone you used in your case, did it make any difference?
I believe that it did make a difference to the liver. Abby Philip had published this last year, and there is another case series which has shown that it may have antifibrotic properties. And I think in our patient, I don't know about the lung, whether it improved because of pirfenidone or spontaneously, but the liver fibrosis definitely improved significantly over the next 6 months.
Couple of questions on mortality in chronic liver, pre-existing chronic liver disease. Now, I think the very good data which is present that the mortality in chronic liver disease is very worsened by the presence of COVID. Worse the underlying chronic liver disease, worse the prognosis is. And so CLD patients go to the ICU much more with COVID than any other individuals. But somehow, as Akash mentioned a little bit, that post-liver transplant, it has been found somehow surprisingly that they do well. They don't do bad, rather, after COVID. I don't know the reason. Akash, do you have any explanation for that?
Sir, tacrolimus is a drug which was thought to have a protective effect, but it has never been systematically studied.
Acalculous cholecystitis, just like amoebic liver abscess, is there any experience of this panel having acalculous cholecystitis as a part of the COVID? I have only 2 cases I remember in the last month which had acalculous cholecystitis. So it's very difficult to say cause-effect relationship. We do see acalculous cholecystitis otherwise also, but I think all these will be assumptions. We cannot have a proof that this has anything to do with COVID virus. Now, there was a question on Hll syndrome, which you talked about. Shivraj, methylprednisolone, should it be preferred over dexamethasone in this situation? Shivraj?
So most of the studies which are done thereof, dexamethasone have been used more commonly than methylprednisolone.
Now, there's another question that the 2 cases which you presented do not fulfill the criteria of HLH. So, why do you at all talk about it?
So, though they do not fulfill the criteria of HLH, as I've told, the H score of both of them were more than 169, which the sensitivity of this is more than 93%. And most of the studies have included H score as a treatment criteria, and they have also improved based on this treatment criteria.
Yeah, what we have to understand is that if you fulfill the criteria, you have to do CD count, you have to do a bone marrow, which is not always possible. So you have to end the treatment whether you.
We lost Mahesh again.
You call it the treatment is same, that you look at inflammatory markers in these patients. I think that was the message which we wanted to convey. Ajay, I think we have stepped over by 3 minutes. So concluding remark by Ajay or by anybody in the panel who wants to say. Otherwise, we'll close in another 2 minutes. Ajay?
I think at least I felt personally learned a lot. and felt very happy that it was a good discussion. I hope the delegates also have gained something out of this, but I will definitely like to have your feedback regarding how you felt about it. Was it a good, does it help us in discussion and all that? There have been, at the end, I'll just answer that there have been a few questions on the emergency endoscopy during the COVID, in the COVID patient. It is not extra harmful. With the due precautions, it can be done. And we have done a significant number of this patient of a liver abscess who was ruptured into duodenum. We had done an endoscopic drainage in the ICU OT, which we have separately in our hospital. Of course, we can't document that. That's the drawback. But then, yes, if it is the GI bleed cholangitis, all emergencies, there's no need to postpone the endoscopy. Yes.
I personally did not pick up these questions because I want Sun Pharma to organize another session where we can talk about endoscopy. It's a huge topic in itself. Good that Ajay touched upon it. But I think we can possibly discuss, it's a changing paradigm altogether. Manu has also published some data on this. So we can have discussion on it sometimes else. Any other last comment, Akash, Manu, VG Mohan Prasad?
So one comment I would like to make from my side. We talked about allergy to the vaccine or vaccine components. So we have to remember that the two components to which which are present in the vaccines are polyethylene glycol and polysorbate 80. And you can actually test for them on through a skin prick test to find out if the person is allergic to the vaccine or not. And depending on the response, you can actually go ahead with the vaccination, even in those who have a history of severe allergy.
But I'll tell you, in my floor itself, we have vaccinated almost 20,000 people in the last 1 month. More than 20,000, and none of them, and this is just within a few meters of my chamber, and none of them had any anaphylactic reaction.
But Mahesh, at the same time, let me qualify this statement. You see, if you look at our hospitals, vaccination, this is probably the biggest vaccination center in the country, that at Radha Swami Satsang, and it has working 24/7. Our experience is the same what you are saying, but at the same time, if you look at the instructions on the Covishield vaccine, it clearly says that if you have a history of allergy of any nature, you should not be giving it. And I have asthmatic, but I have taken it. I have no issues with that. So my advice to my patient is you don't disclose your allergy and go and get it, because I don't find anybody getting any allergic reaction. But if you disclose it there, then the people are refusing.
Yeah, and I just wanted to add, the Sputnik vaccine, which is taken on day 1 and then day 21, because they use a different adenovirus vector when compared to the first dose and second dose. So the global data is 91% protectivity, and the antibodies appear even 1 week after the second dose, which means if somebody needs a 30-day window period protection, probably Sputnik will be a good choice.
I think Sputnik is coming in. My patients are very keen that they should hold on till the Sputnik comes. Let's see what will be the information later on. But I must thank everybody on behalf of me and Ajay, as well as the other panelists and the moderators for, I think we had an interesting 2-hour discussion. We are actually fed up with webinars. And so that's why we wanted to in a little different way. And I think we could maintain a success there. I've been told that 1,600 people were logged in in this seminar. And with that, I'll close. I require Mr. Joseph Gerald to make a final comment. Joseph?
Yeah, good evening to all of you. And at the very outset, I want to first sincerely thank all the participants who were logged in. We had more than about 1,600 participants today. So I think that's quite encouraging. And I think there were a lot of questions, but due to lack of time, possibly we couldn't address all of them. But that this would have been a time worth spent for all of you. And on behalf of the participants, as well as on behalf of all of us in Sun Pharma, we would like to thank today our eminent panelists and resource people who had helped us to get this together. Dr. Mahesh Goenka, Dr. Ajay Kumar, Dr. Manu Tandon, Dr. Akash Shukla, Dr. VG Mohan Prasad, and all our physician panelists who gave in their time to share cases on which the experts also could come in and give their inputs. So thank you, Dr. Ashish, Dr. Mohsen, Dr. Shivraj, Dr. Anil Bardani, and everyone. And thank you all.
And I will request finally Mr. Himanshu to give a vote of thanks to everybody.
Yeah. Thank you, sir. Yeah, very good evening to all the respected doctors. As all good things come to an end, so is this scientific symposium. I, on behalf of Sun Pharma, is pleased to propose a vote of thanks for today's session. As Joseph sir has already elaborated, my special thanks to distinguished moderators, Dr. Mahesh Goenka and Dr. Ajay Kumar, for not only moderating today's session, but they were also instrumental in conceptualizing this session altogether. My also sincere thanks to panel of Indian gastroenterologists like Dr. Manu Tandon, Dr. VGM sir, Dr. Akash Shukla sir, and also along with renowned physicians across the country. As Joseph sir was talking about, we are having a total audience of 1,600 delegates, physicians all across the country, and their definitely contribution has helped us to make the symposium a very great success. Now we can conclude the session. Thanks a lot, everybody.
Thank you.
Thank you. Thank you.
Thank you, sir. Thank you, sir.
Thanks
very much.
Thank you to Sun Pharma. Thanks to Sun Pharma, Joseph sir, Himanshu, Salil, and all our friends. And thanks.
Thank you, sir.
Thank you, sir. Thanks a lot.
As usual, brilliant here, brilliant moderation. Akash sir.
Thank you. Thank you. Thank you so much. Thank you, Joseph.
Thank you, sir.
Thank you, sir.
Recording stopped.
Thank you.
Thank you, sir.